You are listening to Personalization Outbreak, a podcast about the collapse of traditional corporate standards in today's more personalized world. I'm Llopis. I'm a leadership strategist, author, contributor to Forbes, and founder of the Leadership in the Age of Personalization movement. On this show, I'm interviewing executives across multiple sectors to find out how the balance between standardization and personalization can exist. Hello, everyone. Welcome back to Personalization Outbreak Podcast, where we challenge the status quo and uncover the transformative power of personalization in leadership, healthcare, and beyond. Now, I can't tell you what an honor it is for me to welcome Dr. Amanda Saratsis, a dual board certified and fellowship trained pediatric neurosurgeon at Advocate Healthcare in Chicago. See, Dr. Saratsis is not only a leader in her field, providing life-changing care to children with complex neurological conditions, but she's also a visionary, advancing the science of neurosurgery to improve outcomes for patients everywhere. Now, her commitment extends beyond the operating room as she serves on the board of the Pediatric Cancer Research Foundation. Now, Amanda's journey is nothing short of extraordinary. From her beginnings as a piano performance major, with dreams of becoming a concert pianist, to her current role as a trailblazing neurosurgeon. Her story is a testament to the power of purpose and perseverance. Now, before we get started, please click the like button below, share it with your colleagues, and subscribe to our YouTube channel and social media at Llopis. Amanda, thank you so much for being here with us today.
Oh, Glenn, it's my absolute pleasure. It's always a joy to talk with you, and I'm really honored to have this conversation and kind of share some of my ideas and viewpoints regarding kind of the healthcare industry and leadership in healthcare moving forward.
Well, thank you, Amanda. You know, this is where we start getting a little bit personal. And I have to tell everybody that when I first met Amanda, and I'm proud to say that I also serve on the board at the Pediatric Cancer Research Foundation. This is someone, this is the type of person that you don't meet every day. Tremendous amount of humility, her passion for the work that she does to be in service of others. And more than anything, beyond her generous purpose, is this ability in just this desire to get out in front of change before circumstances force their hand. She has what I call this ability to see things in circular vision, with circular vision, to be able to see around, beneath, and beyond the challenges that she faces and the patients and their families face every single day. So, Amanda, you're a gift. I really appreciate you being here. Now, I mentioned earlier in the intro that your intent was to be a concert pianist. Now, when you were a piano performance major in college with this intent, what changed?
It's a great question. And it kind of touches on one of the most challenging choices I've ever made in my life. So yeah, when I went to college, I was actually a dual major, biology and piano performance. And I loved science. I loved being in the lab, but I had played piano my entire life. And this was kind of the natural progression for me to continue my studies in college. But, you know, as I kind of worked through my coursework, I loved being in the lab, but then I realized I kind of desired a little bit more like human connection. So I started volunteering at the local hospital. And I just absolutely loved being in that environment. So I started thinking about, oh, maybe medicine might actually be a better application of things for me. How can I be my best at these two very challenging disciplines? And so after a lot of soul searching and crying and talking with my mom, you know, I decided to pull out of the music program. I still play, but I decided to kind of put my full focus on my pre-med studies with the intent of one day becoming a physician. So that's how I ended up where I am.
So have you ever thought of the interconnections between being a piano, a concert pianist and a neurosurgeon? What are the interconnectivities there? I'm curious.
I love that question. There are so many. The first is the manual dexterity. I initially wanted to be a pediatric oncologist. I was like
Mm.
on this track. I wanted to study cancer in the lab, and I wanted to take care of these really sick kids. And my first clinical rotation was in surgery. And this was by design because I knew I absolutely did not want to be a surgeon. Too intense, crazy. And I loved it. And I'll tell you, the first night that I was on call, which was my first day on service, we had to race this gunshot wound in the abdomen. And, we had to do this emergent surgery to save her. And I'm watching my team in there. And, I'm like bumping into things and I'm a total mess. And the team is so in sync and so well organized. And I'm watching their hands and the dexterity, the beauty of kind of what they were doing. And, they're using their feet on pedals. And there's, the beeping monitors is kind of this like, it's kind of like an orchestra, right? The surgeon was leading. And in that moment, that was a real aha moment for me. I thought, oh my gosh, I'd had all this guilt and regret for kind of walking away from my talents in music. And I thought, this is how I can apply it. This is how I can use my good hands, to render care for people. And so that's when I got the surgery bug. And then throughout my training, certainly they talk about like, the 10,000 hour rule that, you have to practice and practice and practice. I mean, that's absolutely the case with, the technical work that we do in the operating room. So there's just so many overlaps in terms of those two aspects of my life that I think make me a better doctor and, really bring a lot of richness to the experience for me.
So how do you think these two gifts that you have, that you've worked very hard at, how have they helped you become a better leader?
Mm. That's a good question. Yeah, I think, as a performer, any kind of performer that puts themselves on stage, whether you're a solo artist or part of an orchestra, you really have to command a relationship both with the folks that you're working with on stage, or maybe it's just you and your audience. And being a surgeon is being a leader. And, and there's so many ways that surgeons are leaders within their institution. But when you boil it down, a surgeon is the leader in the operating room of a vast and varied team, all of whom are essential. But ultimately, you have to guide everyone as to what is needed, what's changing, adapt to, the current situation, how the case is going, and to really convey that sense of control and ownership, and then allow people to do their jobs too, allow them to be the anesthesiologist to their best of their ability, to allow the nurses to serve the patient to the best of their ability. And that's the same as a conductor in an orchestra, right? They bring out all of the different instruments at the right times, and they're all important. And together, it comes together in this beautiful shared goal. So I see a lot of overlap between those two disciplines in many ways.
I love that. What a great way of explaining it. So in essence, you're not just guiding an orchestra, you're making sure that it's in proper harmony
Yeah.
and in proper flow, which kind of takes me to wanting to explore your mindset. I mean, you believe that all problems are solvable.
Hmm.
Why are you so confident with that?
Hmm. I think, even as a kid, I loved tough challenges. And my mom still says to this day, you always pick the hardest things. And she means it as a compliment, certainly. But I think, it reflects the fact that I do have this inherent belief that, tough problems are worthy of solution, and solutions can be attained with the right amount of work and perspective and talent and grit. You know, I can think of, an example of this as a student of science and then ultimately becoming a physician. There are so many aspects in human history where some of the biggest and most impactful discoveries for human health and well-being have been completely serendipitous. And, you don't know what you don't know. I can give you an example in surgery. At the inception of surgery as a field, there was no such thing as sterile technique.
Hmm.
There was no hand washing. There were no gloves. Um, Sometimes they used the same tools in another patient without washing them first. There were no perioperative antibiotics. And patients got terrible postoperative infections and often would lose limbs or lose their lives. And this was kind of considered just an inherent risk in a surgical
Hmm.
procedure. And it wasn't until the very serendipitous discovery of antibiotics and then some really smart people kind of putting two and two together and saying, hey, if we washed our hands, if we washed the patient before we do this operation, if we gloved and gowned and used a sterile technique, you know, these outcomes can improve. And it was really an amazing connection that was just revolutionary for the outcomes of surgery. And then laid the groundwork for advancing the field and doing more complex operations, longer procedures, things like that. So, there's still so much we don't know, but I think as long as we keep that mindset that kind of anything is possible, I think just requires hard work, creativity, and sometimes just a little bit of luck.
Well, let's go back to something you said. Your mother would say to you, "Why do you like doing things that are so hard?" Honestly, I think you're teaching us all a lesson. Um, Things matter to you. The human connection matters to you, whether you're on a piano or in the operating room. The human connection matters. What advice could you give healthcare leaders right now, given the current state of healthcare? And our audience knows what that means, so we don't have to explain all that.
Mhm.
But why is doing what's hard so important? Because I feel that this is what's taking us away from what I think we ultimately aim to achieve, increase quality outcomes, be more preventive, advance science, and I go on and on. What do you tell people that are either afraid or don't have the will to do what's hard?
I used to have a saying that I shared with my trainees, and I say, hard things are worth doing. And it doesn't mean that easy things aren't worth doing, but it's really the hard things at the end of the day that matter the most. It's the big challenges. And you have to keep in mind that in terms of a recommendation I make to healthcare leadership, that like we're all in this for the same reason, or at least I'd like to hope we are. I know it's a business. You don't have universal healthcare in this country. We have to keep the doors open. But at the end of the day, it's about the care of the patient, right? And that is everything from their outcomes to their experience as a patient. I see it when I go into the hospital or the clinic. Being a patient is terrifying, and there's so many aspects outside of even like the technical delivery of care that affect the patient experience. And some of these things are these kind of baked in just ways that we do things that it's really hard to kind of unpack and change. But I think if we kind of we're critical of ourselves and think about like how can we do this better to make patient experience better, those are hard things, and it requires changing culture. It requires changing in perspectives. It requires an acknowledgement of the shifting ground underneath us in terms of the patient-physician relationship. And those are all really hard things. But at the end of the day, if we are honest with ourselves and acknowledge that those are issues that need to be addressed, even though they're hard, I think we can make tremendous impact on the quality of the care that we deliver in this country.
So let's go back to the physician or provider and patient relationship. How have you seen this relationship change, and what forces have really driven this change?
Mm. Yeah, I think it's changed a lot over time, even from when I was trained in medical school about 20 years ago now to the way that we practice now. And I think what's driving it is really access to information. We live in the information age. We have access to the internet. We have electronic medical records. This has really democratized access to information and knowledge kind of in all aspects of our life, not just science and medicine. People have little computers in their hands. They can look, they can Google things, they can look things up. And I think that in response to this access to information, there's unfortunately been a concomitant erosion of trust
Hmm.
in professional and expert relationships and laymen. And with it, this is kind of weakened relationships in many fields, but also in historically very paternalistic um, shaped delivery of medical care. And I can give you an example. My grandmother, who's in her 90s, has always been completely deferent to her physicians, right? What the doctor says, yes, doctor, thank you so much. And then she won't ask any questions because she doesn't want to offend him. And then I'll call her and say, what did the doctor say? What's the plan? She'll tell me the plan. I'll say, well, did you ask this, or do you understand that, or what was his thinking on this? And she's like, oh, I don't know, that this is just what he thought was best. And certainly not to undermine the knowledge or experience or perspective of the physician, but on the flip side, now I have patients that come in, they have Googled their diagnosis,
Hmm.
they maybe have joined a Facebook support group and have talked to other patients, families about the diagnosis and kind of what the options are. They're very well informed, or maybe poorly and not well informed, even though they think they're well informed, because there's just so much information out there. And that, again, as I mentioned, it's really kind of shifted the dynamic. And so patient care really needs to step away from that sort of traditional hierarchical, like, I am doctor, do what I say. And we really need to become partners with our patients and their families, enable them to feel empowered to make choices in their care, send them to credible resources, let them get second opinions by trusted colleagues so that they feel like they can trust you, and we are looking out for your best interests. In turn, physicians, it's the same thing for us. We really need to be given the structure, administratively, really, to be empowered to engender these relationships. And I can give you an example. As a neurosurgeon, often what I do is split second decision making in a very emergent, scary situation for families. Whisking a kid from the ER, previously completely healthy kid, terrible diagnosis, whisking them to the operating room without much time to talk or engender that relationship that I just was speaking about. But then
Mhm.
on the back end, I make sure that I sit down with that family. We look at the films, we talk, I let them cry, I explain the team of providers that are going to care for their kid, and I really try to build that rapport. And then in the clinic, by design, I have my consultation, my new patient appointments booked for twice as long as my return patients. And the reason for this
Hmm.
is, we're facing really complicated medical problems in my clinic, and it requires a long conversation and a chance for them to digest the information and to ask me questions. In contrast, so many of my friends that are in non-surgical specialties, primary care physicians, they have to see patients in like 10 and 15-minute increments. And these are patients that have multiple comorbidities, complex histories, maybe don't understand how to take their blood pressure medication or manage their diabetes. And they have to do a history, a physical, then write the electronic medical records. So they see 50 or 60 people in a day. That's just not reasonable. It's impossible to give the best care in this environment. And this leads to physician burnout. They're exhausted. They feel terrible. They feel like they're not delivering the best care that they can deliver for their patients. And then patient noncompliance, right? Patients either don't understand or don't have the information they need, don't take their meds, and then they end up with worse problems and end up, in the emergency room with terrible sequelae of their, improperly managed medical problems. So, unfortunately, we need to set physicians and, all medical providers up for success from an administrative standpoint, from a leadership standpoint. And we want to do our best by our patients, and we need the organizational support to be empowered to be able to deliver that care.
Well, we could talk about this one question for a while, but I want to just, I mean, let's go to what we know has been happening for some time and we're struggling with. But this is an opportunity, and you've already identified it. But is it patients or consumers?
Mm,
Uh,
mm,
Employees for institutions are consumers too. They both have they have choices. So when they reach this level of burnout, maybe not so excited about their workplace, the work environment, they have a choice to make that can put undue risk on the industry, let alone patients and the institution that they serve. And then you have patients who are consumers, like you said, they're more informed, perhaps not the right information. Have you found yourself at times debating with patients? I mean, how
mm.
how thick do you think the layer is between those that trust and those that don't trust enough?
It can be pretty thick. And I won't say it's the norm. And I will say that the vast majority of the patients that I interact and my colleagues interact with do form that relationship and do trust. But I've also increasingly been having conversations with my colleagues and, kind of talking this through, these frustrations where they're making really solid, well thought out, good judgment medical recommendations. And families are either distrustful or, they're scared. They question, the practitioner's knowledge or experience, and they hesitate to pursue, in this case, what's in their child's best interest. And it can become very tenuous and very, very challenging and very upsetting for us because it pits us against our patients in a way. I had an experience years ago with a mom, very complex social situation, but she had a baby that, a very complicated birth, and the baby suffered some brain damage and some really terribly significant sequelae, downstream to that. But because of that experience, she was so distrustful of the medical industry as a whole. And this child ended up in the intensive care unit. She ended up needing a relatively urgent neurosurgical procedure because her brain was seeing some swelling of fluid spaces putting pressure on her brain. She really needed this procedure, and the mom was so against it. And I really struggled because, I asked for help from the ICU team, and we'd try to have these care conferences, and she just wouldn't listen. And we got second opinions from all my partners, and they'd say the same thing, and she just didn't feel comfortable doing it. And the clock is ticking on this little baby. And ultimately, in reflection, we did get her to finally agree, but it took weeks of long conversations and phone calls. And
Wow.
I really wish that the institution had stepped in at some point, and had really kind of helped, instead of pitting me against this mom as like this person, trying to convince her to do something to her baby that she really didn't want to have done and was just really, really scared about it. And so there's these really nuanced complexities with these patients, where they're coming from, their past experiences, their knowledge or lack thereof. And so the layer can be really, really thick, really to the patient's detriment, honestly.
Well, in this, the way you described this, just so our audience is clear, is that this is where we start seeing this nuanced behavior that is forming the personalized belief of an individual. Whether they believe whether you think it's the right one or not, they have an opinion now.
Mm-hmm.
What type of leadership behavior changes at the institutional or organizational level do you think need to be implemented to foster a more healthy patient-physician relationship? Because I've got to believe that in many respects, while the layer maybe hasn't been that thick in the past, as it gets thicker, we need to start making some changes. And what do you think some of those should be?
Yeah, I mean, I think I've seen some of these changes implemented, and I've seen them work. I've seen, when we round in the intensive care unit, we round as a team, and we bring the parent out into the hallway as we present and discuss the plan, so that they are here. And it's not necessarily always in layman's terms. Kind of running through data and vitals and plans and things, different medications, but they at least feel like they're part of the conversation.
Mm,
And I've seen attempts to really bring the family, and I'm a pediatric specialist, so it's kind of a different situation than in adult medicine, but there's always parents there that are ultimately the decision makers for these kids. And so bringing them out into that conversation on a day-to-day basis, giving the families the opportunity, direct access to the opportunity to talk to people in positions of authority, like a charge nurse or someone, if they have concerns about what they're observing with
yeah.
their child's care, has worked really, really well too. Um, I think also kind of changing the whole dynamic from a leadership point or standpoint, in terms of how teams are built and run and led, making it clear what role everyone has on the team, instead of being this big scary group in white coats that the families can't differentiate who is who. And then also from a leadership standpoint, really empowering the people, the various practitioners on a multidisciplinary team to do their best, and to kind of you know use their skills and their expertise to make recommendations and decisions that are backed with facts that are backed with references or citations or resources that the families can also access and review as they're trying to make these difficult decisions.
As I hear that, this is a classical case of where standardization has dehumanized um, those that can actually add more value and be part of the decision-making process for a healthier whole.
Mm-hmm.
And now you're saying, Glenn, we have to get rid of that. This maybe it's knowingly or unknowingly creating this environment of dehumanizing our people rather than making sure we know the right people in the right roles. We know who has the expertise to help this. Because if not, we're just putting too much of a burden on people like you. And it's not just you. You play a role, but like you said at the very beginning, your role is to help create the right harmony between all the players on the team. But as you look at this more broadly throughout the institution, are there really enough Amandas there? Do they have that skill set to do that? I mean, are we even finding that on the leadership team? So what I'm finding here is that you do an excellent job of of catering to personalization, while there may be other parts of an organization that may not be.
Mm.
And I think that this just puts not just the organization at risk, the quality of care at risk, but it puts the parents at risk too. So have you ever observed this need to shift away from standardization to personalization in healthcare? And are there some examples that you can share?
Yeah, absolutely. I mean, I think it's not all dire, right? I do think
Yeah.
there have
Mhm.
been some great shifts towards personalization. And again, I think that group rounding with the family
Yeah,
was
great
a brilliant
example.
idea. And I hope more institutions are doing that. But, I've seen this kind of both on the patient side and on the practitioner side. In my discipline, for patients now, we have the technology and the tools to rapidly and deeply sequence brain tumor tissue samples or other samples from our patients to get a
Mhm.
molecular diagnosis, to get a clearer picture of the drivers of a tumor, the molecular biology of the tumor, and then we can stratify that patient to more appropriate therapies based on the presence of nuanced genetic characteristics like a mutation or what have you. And historically we were just treating like all gliomas the same, and now we know there's like many varieties of glioma, and depending on what the molecular biology is, and even whether it's an adult or a kid, that's why the standard protocols weren't working. And now we have better, more personalized protocols that we can put these patients on, and it's increased outcomes considerably. And also looking forward, we're using machine learning, we're using AI, so we can kind of predict what meds they'll respond to best, or predict how much minimal residual disease they have, and then preemptively strike, and which again is just like a totally new way of approaching cancer care in this case. And then, from a practitioner standpoint, I think that the old guard, that when you think doctor, and even for me, when anybody's ever talking about seeing their doctor, talking to their doctor, I imagine a middle-aged man. Like I still do, even though I am a female and a doctor. And I have so many friends who are female doctors. I kind of ascribe to that stereotype in my mind. And, I am one of barely 200 female board certified neurosurgeons in the United States.
Wow.
And despite the fact that women now make up over half of medical student classes, we are grossly underrepresented in the surgical specialties. And why does this matter? Well, there are probably tons of bright people that are kind of driven away from these fields because of this old guard, this old culture, this old way of doing things. And I think we really need to change that culture so our best and our brightest and people who, may not have pegged themselves as someone who had the temperament to be a surgeon say, hey, I could do this. And this matters because there are recent articles in major medical journals that showed that surgical teams led by women have better outcomes. They have less surgical infections, they have less hospital admissions to the hospital, and they have less surgical complications, including rates of death. And so, I'm not saying that all surgeons should be women, but what I'm saying is think of all the patients that we wouldn't have helped if we didn't open our minds to the fact that like women can be on this team too. And that you can extrapolate that to, it's not just a gender thing. It's people from different backgrounds, different races, different perspectives that need to be brought in, and so to kind of allow that sort of personalization of care. And so our teams are not just homogenous, but have people with, different skill sets and abilities, and they're all valuable, they're all useful, but it's rather than forcing people or forcing patient care to be done in this kind of status quo standardized way, one for all, we need to kind of open up and let that personalization in for the betterment of everyone involved.
That's exactly why that's so important.
Mhm.
That's exactly, I don't believe that. You said 200 or 300?
200.
Unbelievable. So I like to just take a step back. You had mentioned a couple of times, I want to make sure that our audience appreciates the work that you do, Amanda. Can you maybe share with the audience a little bit about the state of pediatric cancer?
Mm.
Where is that? Why is this such an important field? And what type of risks do we face today?
Yeah, so pediatric cancer is a really big problem. Its rates are actually going up. Pediatric brain tumors, my field, are the number one cancer killer of children. Um, Unfortunately, there is less and less interest in pursuing pediatric specialties because, kind of the workload that I described. It's a really hard job to be a pediatrician in a clinic day after day after day, seeing all these kids and barely feeling like you're scratching the surface. And then concomitantly, there's this grossly disproportionate amount of funding for pediatric research as compared to adult cancer research, like on the order of like hundreds of times. And so, you have all these smart people who really want to make a difference in the care of these kids, and they don't have the resources to do it, or they either don't have access or they don't exist. And while we have made incredible strides in some pediatric cancers like leukemias, and the hematologic malignancies used to be the number one cancer killer of kids, and because of research and advancements in the field, that is no longer the case. But we still have a really high mountain to climb when it comes to parity for kids, when as compares to what is accessible to folks that are trying to improve care for adults.
So explain to us why pediatric cancer, the risk it can place on humanity, given some of the challenges, funding issues, etc. I mean, give us a broader, more macro sense of where this is at and how this can affect the future if we don't get out in front of this.
Yeah, I mean, it's scary. It's really scary, the thousands and thousands and thousands of children that die from cancer every year. And if we can't improve those numbers, that kids are our future. I know it's trite, but these are the great minds and leaders of the next generation. And it's not just the kids, it's the whole family, it's the whole community that gets affected by it. I've seen it even in my own family, the way that the dynamic shifts when one kiddo has, a terrible cancer that they're dealing with. All the resources, time, attention, money have to go to the care of that child, often at the expense of attention for other kids or someone's job. I mean, it's an incredible burden on these families and on society as a whole. And it's expensive. Um, their care is incredibly expensive, and the vast actually majority of kids are on Medicaid. There's not even like the financial resources to care for
Mm.
these kids. And so it's just a tremendous problem, because if we don't take care of our kids, they're going to be dealing with problems for a lifetime that are going to be more expensive or more disabling, or they're not even going to make it to that future in the first place.
And just to put this in proper context, and correct me if I'm wrong, is it every 2 minutes a child is diagnosed with cancer?
Hmm.
I mean, just to give people a perspective.
That's crazy.
So going back to, and thanks for sharing that. I don't think a lot of people know this in the
Hmm.
general public, and it's important to create that level of awareness. So thank you for taking a moment, Amanda. Now, if you going back to personalized medicine, you talked a little bit about how institutions and organizations can better prepare for the future, given, recent advances in science and technologies? What more can we do? How can we accelerate this process?
Oh, that's a really, really good point. I think, as a whole, I think the context for your question is a good one because the process is frustratingly slow, right? Healthcare is this sprawling enterprise and there's so many moving pieces and it tends to be very, bureaucratic and it's hard to implement change quickly. Um, and I think that if we don't take the perspective that we need to be more nimble, that change is not going to happen. I've seen this in real time. Adopting new technologies, for example, at an institution like ours, it takes capital, it takes buy-in from the administration, it takes
Mhm.
entertaining different vendors and getting quotes and blah blah blah. And but you want to get that operating microscope in, or you want to get that surgical robot in because that's going to improve outcomes for patients, and it's also going to bring patients to your institution, right? Because patients really like the newest, latest, greatest technologies. They want to know that they're getting the best possible care out there. And so I think from a leadership standpoint, I think that physicians need to be heard. And in my perspective, it's surgical, right? It's surgical tools, technologies,
Yep.
and things. But we need to have an awareness of the technologies and new things that are coming down the pipeline sooner. Administration kind of needs to hear their surgeons and say, hey, these are the people who are in it, who know what is needed or know what is coming. And they need to have the kind of the flexibility and the agility and the nimbleness to say, okay, let's make this happen in a way that is financially sound, but within a reasonable amount of time so we can enact these changes kind of in real time.
And what are the consequences if that doesn't happen?
I mean, I think that we can't do our best. We can't deliver the best care that is possible for patients. I can think of it. I can think of two examples. So one example, when I was a junior resident, every time I was on call, I one of my jobs that night would be to run from the opposite end of the hospital where the ICU and the ER was. It was basically like a 10 or 15 minute brisk walk to go and get films, like plain films, the big,
Mm.
ones that were printed out that lived in the clinic, and then run them back to the other side, get them ready for our didactic session in the morning where we review the images, talk about the surgeries for that day, make a plan, teach the residents, why that's the best plan, what they need to be thinking about. Really important stuff. But I'm also the on-call neurosurgery resident. I'm the only
Mm.
neurosurgeon in
Mhm.
the hospital. And if that pager goes off, I'm now stuck with this Sophie's choice kind of situation, right? Where I'm like, do I have time to go and run and get the films, lest I get totally reamed in the morning in front of all of my peers and professors and get into a lot of trouble and piss everybody off? But that's at the risk of leaving this patient who might be in dire straits and needs me right away. Or do I go and get the films and kind of hope for the best? And what does this have to do with technology? Well, the technology at that time existed to digitize imaging. Our hospital just hadn't implemented it, and it certainly couldn't read discs from outside institutions. There was no fidelity in terms of that technology. And now today I can see images immediately on my phone, and
Right.
the rapidity with which we can deliver care, the access to that information across my entire team immediately speeds up care, takes these ridiculous tasks that we used to do. I mean, that's why they called us residents, right? We lived
Yeah.
in the hospital because there were all these things like running and getting pictures that kind of have to do with patient care and your education, but really was kind of what we call scut work, you
Mm.
know? And so, and then on the flip side of that, it affects our job, it affects our efficiency, but also it affects patient outcomes. For example, craniofacial surgeries, where we kind of reshape skulls of babies that are, not formed properly for various reasons, are very bloody cases. And little tiny babies have very little circulating blood volume. It doesn't take much bleeding to put them at cardiovascular compromise. And so big cranial vault reconstructions, even 15 years ago, were exceedingly dangerous and exceedingly challenging. And their postoperative care in the unit was very tenuous and scary, and they would need lots of transfusions. Fast forward today, most of this can be done endoscopically through very small incisions, minimal blood loss. the kids are extubated and like eating the next day, no
Wow.
transfusions. So, no risk of exposure to bloodborne anything or transfusion reactions. Just a totally different paradigm now for managing these patients. And that's because of technology. That's because the hospitals brought in the scopes, they taught the surgeons how to use them, we practiced, and we got better and we got faster, less anesthesia time, and so this technology is really important because it really can change how well we can do our jobs.
Well, I asked you to elaborate on that, and I appreciate that you did. And I want to share something that I'm still exploring, so the story isn't done yet. Um, Forbes has asked me to write a piece on what high schoolers are saying about their future careers. And here's a data point that came out from the National Society of High School Scholars. 3 out of 4 would want to pursue a career in healthcare rather than technology.
Yeah.
Why? Because with AI, many of those jobs in tech aren't going to require a human. And and these students are realizing that they're very connected to humanity. They themselves have a more of a human connection than older generations. And they want to be now in fields where they not only can get that human connection, but they can get that level of stability in their careers.
Hmm.
What advice do you have to those young high schoolers who want to be in healthcare because they perceive it as this institution that's about caring, saving lives, finding stability? And yet, as you say, we still, while we're doing fantastic work, we need to do things faster. What's another reason why this desire that they have is so important, and what would you advise them?
Well, first of all, that is heartwarming data.
It's incredible.
That wasn't where I thought you were going with that with that data. I'm really, really shocked and surprised, like pleasantly surprised. It's wonderful. I would tell them keep that perspective because at the end of the day, we don't, I mean, maybe some people go into medicine for different reasons, but most of us are there because we want that patient facing interaction. We get so much fulfillment from this virtuous work. I like to call it virtuous work, work where you feel like you're making a difference. And you can see it in real time. And that, there is absolutely nothing more rewarding than like forming these bonds with these families and these patients and the gratitude and the love that they feel for me, to be able to watch these kids grow up healthy. It is just, it's there's nothing like it. It is the most rewarding experience. And despite all of these negative things that we've kind of been talking about, these obstacles that need to be addressed,
They're all opportunities. They're
they're
all they're
all opportunities. And I think that as technology advances and as financial pressures shift and ebb and flow, I think at the end of the day, we everyone is there at the table to take care of patients. And so I think looking at things through that lens of doing hard work and doing virtuous work is really rewarding. And that's what keeps people committed to their field and wanting to stay and not burning out and not jumping to a different industry, as so many people are doing these days, right? Um, and I think that the healthcare industry, because of conversations like this, really does have the opportunity to step
exactly.
back, kind of look at what's coming, look at where we were, look at where we are, and say this is where we want to be. We that kind of consumer philosophy, I think that you mentioned is a good one. Not just the patients, but the employees as well, both being consumers of what this enterprise is, so that people do want to go through rigorous training and medical school debt and all these things to be able to continue to push forward the health of our communities.
And where the industry can be. And this is
Yeah,
why I shared this statistic because it surprised me too. But
yeah,
it made me feel warm and hopeful because we need them. On the flip side, and I like to close with this, and I'm sure I know you're going to say something extraordinarily meaningful because you're fighting for this every single day, Amanda. I just spoke to a group of second year master's students in health administration. And one of the questions that I asked them was, is healthcare losing its dignity? And unfortunately, they said this is one of our biggest concerns. What gives you hope that we are either better than what they think or that we are on a path to reclaiming it faster than one might think?
Hmm. That's a deep question.
Well,
Um,
this is what's interesting, though, as you gather your thoughts, is it is, but imagine that these students are that in touch to
yeah,
even have an opinion. And that's
yeah,
why I bring it up, because when you think about pediatrics, I mean, this is the epitome of dignity, human dignity for that child and their families.
mhm,
And now we were talking about pediatrics, but again, this is part of, these things have to come from somewhere. I believe that pediatrics plays a huge part of that.
mhm.
But what advice or what perspective could you share with these students that it's not as bad as you might think, or it's already starting to get better, and if not, this is why you think it can?
Yeah. Well, first of all, I am again really surprised by their insight. And I think they're right because, from their perspective, maybe you're only getting this information by being a patient themselves and having that personal experience or knowing someone who's been a patient. And being a patient, I work mostly at the hospital. So, being an inpatient in the hospital strips you of so much dignity, right? You're wearing a hospital gown, people come in
Hmm.
at all hours of night, you know, some of them might not remember or know your name or get your name right. You are totally helpless, right? You are at the mercy of these strangers. And it feels like a loss of dignity and autonomy. And for children, they don't even have the agency
Right.
to say no. I mean, teenager, when they get older, they can, but like, how do you explain to a 2-year-old while you're giving them an IV why, and with their mom standing next to them, that this is like for your own good? That's a really scary thing to watch for, everyone involved. But I think we are more attuned to it than ever before. I think that I think you're right. I think it's certainly better in pediatric circumstances. I think we're more attuned to that and we're more gentle in our approach. But even in adult medicine, I think that we've come a really long way in terms of respecting our patients better. In terms of, again, I refer to that sort of patriarchal, hierarchical model system. We don't just bluster into a room, say, we're going to do this to you and bluster out. Like, we really have learned that that's not the right way to treat our patients. That's not how anyone wants to be treated, right? And we've really we've worked into medical education programs, classes about this. We've worked into training around difficult situations, difficult scenarios, difficult conversations, delivering bad news. Really, really more. It's more salient. We're more in touch to the need to kind of maintain the patient's dignity. And I think that as long as we have young people like this who are aware and attuned, and it's a salient point for them, it can only get better. Absolutely.
Well, Amanda, I can't thank you enough for taking the time. I mean, we can just keep talking. I mean, I can't believe how time has flown by, but thank you so much. It's leaders like you that will not only inspire the next generation, but also those that are um, working hands-on as we speak.
Yeah.
So thank you for your continued extraordinary work and just your leadership. When I first met you, I thought to myself, wow, what a presence you have, your knowledge and understanding of what's right, and just making sure that we continue to push the envelope at a speed that remains its quality while continuing to deliver dignity to people. So thank you so much for everything you do for us, and let's make sure that we get on the phone real soon.
Thank you, Glenn. No, I really enjoyed this, and I owe you also a debt of gratitude to elevating this conversation out to the masses too. People really need to be thinking about these things and kind of ruminating and putting our heads together to make really impactful change, which I think is entirely possible. But I
Yep.
also think, it's imperative. So now's the time. So thank you for this conversation, and I look forward to talking again soon.
Amanda, thank you so much. And as I leave every show, when you lead in the age of personalization, you will see things that others don't. Do what others won't and keep pushing when prudence says quit. Thank you, Amanda. Really appreciate you.
Thank you, Glenn.
Thanks for listening to Personalization Outbreak. Make sure to subscribe so you never miss a show. If you enjoyed the content, visit ageofpersonalization.com to check out our free streaming video series and learn how to get involved in the movement. I'm Glenn Llopis. I wish you a good day, and remember, without strategy, change is merely substitution, not evolution.